The content discussed in this episode may be specific to the guest's organisation or location and may not be applicable to other organisations, states, territories or countries. The material presented in this podcast is for general information purposes only and should not be considered health, legal or financial advice. Medical administration is a rewarding profession, but it comes with challenges. So what is it like, and what should you do if confronted with a monumental administrative difficulty? This is the podcast that takes unfortunate scenarios and explores the essentials of clinical governance to find solutions. I'm Dr David Rankin, a very experienced medical administrator and lead fellow with the Royal Australasian College of Medical Administrators. And this is Safeguarding Healthcare, the essentials of clinical governance. Today, an infected doctor.
This is a real ethical dilemma.
That's Dr Paul Douglas, the Executive Director of Health Protection with the New South Wales Ministry of Health. He's a very senior medical administrator who's also worked as the Global COVID-19 Medical Coordinator with the United Nations Migration Agency. And I'm presenting him with a challenging scenario.
First and foremost is this doctor cannot work until you've looked at what the actual risk is. So they have to stop immediately.
In today's scenario, the head of department for orthopaedic surgery makes an appointment to talk with you. They have recently seen their GP as they've been feeling weak and lethargic for several weeks. The GP ordered some blood tests and made a diagnosis of hepatitis B, despite the surgeon being fully vaccinated. The surgeon recalls being splashed in the eye with patient blood about 3 months ago when they were asked to review a patient in the emergency department. The patient was involved in a fatal car accident and was very drunk. The scene in the ED was chaotic, and the doctor simply wiped the blood away and thought no more about it at the time. I started by asking Dr Paul Douglas what key issues this scenario raises.
It's multiple concerns here. One is, first up, what happened at the time of the incident 3 months ago, and was it reported, why wasn't it reported, and what's the culture of the organisation not to do that? And we can understand in busy organisations that might happen. I think, secondly, concern would be, has this surgeon been complying with the requirements under APRA and monitoring his hepatitis B status, as is supposed to have been done under the national guidelines, and that commitment every year? The third level is that this is a real ethical dilemma. We've got the public safety, but we've also got the right of the healthcare worker to practice without prejudice while suffering from a bloodborne virus, or in this particular case, a hepatitis B infection. But it's not an uncommon scenario. I think the uniqueness of this particular scenario is that the healthcare worker had believed he was immune, having been vaccinated in the past, but now has found that he's not, which then creates all sorts of problems for his work, his future, his respect as head of the department, and a number of other things that I'm sure we'll explore, David, as we go into it a little bit deeper.
Thanks, Paul. I agree. In relation to testing, the CDNA national guidelines say healthcare workers who perform exposure-prone procedures should be tested for HIV and hepatitis C every 3 years. Hepatitis B is not so clear. If a doctor can demonstrate immunity through vaccination or a resolved infection, they may not need to be tested. In this case, the surgeon did not have immunity, even though they had been vaccinated several years previously. Let's start off with the risk to the patients. If a surgeon continues to operate, surgery inevitably involves blood. And although the surgeon and all the theatre staff wear gloves, and often double glove, there is a chance that the surgeon's body fluids will mix with the patient's body fluids and transmit the infection. So what are the risks to the patient if this surgeon continues to operate?
Well, the risks are probably very small if the surgeon's complying with all the recommendations they should be doing. However, orthopedics can be quite a difficult procedure. So while the risks are low, there still are some risks to patients. It's interesting. I've read some literature around this, David, and in Canada, they've said in situations like this where the risk is greater than 1%, then the patient should be told that there is a risk. I looked in some of the research and saw that some of the surveys they did with patients is that 93% of patients expected to be told if a surgeon had a bloodborne virus. Yet that's not what our national guidelines tell us. So that's where the ethical dilemma comes. But I think the risk is very low, but there is still definitely a risk. It gets worse depending on what the viral load is. It gets worse depending on whether the doctor has got a hepatitis B E antigen. And so a number of things need to be considered before this doctor should be allowed to do exposure-prone procedures. And we can talk about that a little bit more because there is a risk to the patient, and the patient needs to be aware of that if this is the only alternative.
Even with a very low risk, I think the majority of patients would be very cautious about exposing themselves to that risk. So we're suggesting that the links with the patient that presented to the emergency department, how do you confirm that link in exploring where the surgeon picked up the infection from?
That is really difficult, David. We know there are 9 different genotypes for hepatitis B. So that potentially you could look and see if the genotype is similar or the same, but even then that doesn't tell you it's the exact same virus. And I'm not convinced that it's helpful in trying to say whether that was the exposure or not the exposure. And so if you can authenticate it, then that would be fine. But then you've got to get the patient permission to say, can I actually take blood tests from you to see whether you have got hepatitis B as well?
So what are the options for the surgeon?
Well, there's quite a few options and where we go. I mean, in the jurisdiction I work in New South Wales, it's very prescriptive about what's expected, what should be done, and where this goes. So the first thing that happens, and as this surgeon has done, he's reported to the designated officer within the hospital, which in most circumstances will be the Director of Medical Services or the Director of Nursing. And that fits under the Work Health and Safety Act, that there are certain obligations that we have to the employees in doing that sort of stuff. I think the other thing that's driven behind this is the national guidelines for the management of healthcare workers living with bloodborne viruses and the risk and who perform exposure-prone procedures. So that's a national guideline which was developed by Communicable Disease Network of Australia in 2018, and it's mandatory to report to APRA and to your employer if you do have a bloodborne virus. So the surgeon's done the right thing in the first place. In terms of a healthcare worker who has an exposure-prone procedure, there are a number of things that then we need to do. The first and foremost is this doctor cannot work until you've looked at what the actual risk is. So they have to stop immediately. In terms of the surgeon and the employer, confidentiality is a must, and that's part of a duty of care. So this needs to be kept quiet and dealt with in a way which is respectful to the surgeon as well. In terms of what then needs to happen is that the employer would need to work in conjunction with the clinician who is looking after the surgeon, again, assuming the surgeon gives that as approval to go talk to the clinician. And in New South Wales, we can actually do it under a public health order if need be, if the person's not compliant, to talk to that particular person. But first and foremost, the healthcare worker must report and inform the facility. They cannot perform EPPs until that assessment is undertaken, and they must report any and all possible instances where the patients may have been exposed over the foreseeable past, if you like. In New South Wales, we have an expert panel which reports to the Chief Health Officer, and any healthcare worker who is in the situation will be referred to that panel, not personally, but in terms of the circumstances and what the issues are. So that panel then can make a decision about what they think the risks involved in this, whether that person can continue to work or what work that person might do. There are a number of factors that they look at, and we can go into the medical side of that if we want, but all that's going to be around the viral level, whether they're HBe antigen positive, what surgery they're doing, the durations of the surgery, and whether there's any procedural skill level the surgeon themselves might have. So that's a lot of investigation to go on. But at the end of the day, if the panel deems that this surgeon cannot do exposure-prone procedures, then be where that ends up. Doesn't mean being head of department means that they can do other things. But again, that's this ethical dilemma. What's the right of the patient? What's the right of the clinician in this situation? Again, we'll come to compensation. I'm sure you'll talk about that later, David. But when we look at whether this is a private surgeon working as a visiting medical officer, running their own business, or whether this is a surgeon who is employed directly by this service, also may make a difference about how this case is handled as things go forward to try and balance the risk to the patients and to any future patients in the community themselves.
It can, of course, be quite catastrophic, particularly if they're a private surgeon as far as their income goes. There's lots of other things that surgeons can do, outpatient medical records, audits. And if they can't do the surgery, it's really career limiting. What about protecting the person's privacy? They are a person. How do we ensure that their privacy is protected?
This is really difficult, particularly in medical environment, and often these departments are extremely small. So where you're asking a surgeon not to do exposure-prone procedures, no matter how much you try and keep it quiet, people are going to be asking questions about why this is not the case. But as a medical director or administrator responsible for this, you have to be very careful not to make any comments around that. You would work with the surgeon for them to look at what sort of messaging that they might want to give to their colleagues and to others who are out there. But paramount and first and foremost is that requirement and that duty of care to the surgeon that you do maintain that confidentiality. And where people are asking questions, then probably referring it back to them to go to the surgeon themselves to have that discussion rather than hear any rumours or hearsay that might be going on.
They're likely to work at multiple organisations. Head of department implies they're in a public hospital, but they'll probably have a private attachment. How much information can you share with your colleagues in other hospitals where this doctor works?
You have a duty of care to the person who's in front of you. That's first and foremost. And that person, if they are abiding by the national guidelines and abiding by their registration, then one has to, and I hate saying the word assume, but one must assume that they are going to do the right thing in terms of other employers or contractors and things like that. They are obliged to report this to APRA. That's part of the referring to the advisory panel, that's a thing to do. And so in reporting that to APRA, they then need to say that I am no longer able to work in this procedure. And so theoretically, APRA would be the ones, if they wanted to notify other organisations through conditions of registration, they can do that. But I think the obligation is on the surgeon themselves. You as an employer need to make this very clear to the surgeon that if they are working at other organisations, that they should be informing those employers or having a break from that employment until the matter is resolved through, as I would say within New South Wales, that expert advisory panel who will provide the feedback to the Chief Health Officer about what this officer can or cannot do. If the surgeon refuses to abide by those rules, then there's an obligation to report that to APRA. And in New South Wales, the Chief Health Officer can actually, under the Public Health, order this person to stop doing that work. So there's quite strong powers to ensure we keep the safety of the community paramount throughout this process.
It's an occupational hazard, bloodborne infections. You've already mentioned that surgeons are required to have regular tests of their bloodborne infection status. But can you require medical staff to be vaccinated?
It's a good question. Now, in the public system, we can, and we do. If someone refuses to get vaccinated, if you now apply to a public hospital in New South Wales and you refuse to get vaccinated and you are not immune to hepatitis B, we could still employ you, but if your main employment is doing surgery, then we probably wouldn't employ you if you refuse to get that vaccination. But no one can compel anyone to be vaccinated. But it's, again, an issue that needs to be handled sensitively. The person needs to be informed about the consequences if they do not get vaccinated, and that their rights of practice will be very limited in what they can do if they don't abide by those rules. And we saw this during COVID and some of the fallout around that, and how we saw employees within the public system removed from their duties, and some even lost jobs, which has had consequences since, but that's a different discussion.
We've briefly mentioned informing patients going forward that their surgeon may have a bloodborne infection. What about past patients? This surgeon has been operating for several months since they initially contacted the infection. Do you go back and contact past patients to find out if there's been an issue?
Yeah, well, this is what we call look-back exercise, David, and it's defined as a process where we identify, trace, recall, counsel, and test patients who may have been exposed to an infection at the time. How you determine whether you do a look-back exercise is a really good question, and it's a really significant and costly exercise. So it's not something you just rush in and do. So again, through New South Wales and this jurisdiction, we're very lucky in that we've got the Bloodborne Virus Advisory Panel who works in conjunction with the Chief Health Officer who determines the level of risk from the information that they see from the surgeon themselves. And they will determine then what they might do in terms of a look-back exercise, the extent of that exercise, and then go through that process. And it's very strictly controlled to ensure that, one, that we're not scaring the community overly much, but two, that where patients really are at risk of having been exposed, that they are identified as soon as possible under that look-back exercise and the regulatory authority that we've got around that.
One of the challenges is that a condition like hepatitis B can take months to become apparent. How long do you monitor potential at-risk patients for?
It's doing testing on the patient. So the ultimate thing is you do a blood test. And again, it will come down to some of the other factors that I talked about a little bit earlier about what is the risk of transmission? What's the viral load of the surgeon? What's their status of HBe antigen? What type of surgery have they been doing? What was the risk of actually blood transmission or transfer of blood between them? And what was that route? Was it percutaneous or was it mucosal or whatever? Of course, they all carry slightly different risks in that regard. Normally, the virus will show positivity within about 6 weeks. Can be up to 3 months, but usually that would be the sort of monitoring period if you're looking at that. And there's no sign. So a patient that was operated on 3 months ago, you would expect to be positive by this stage. It's those who are most recent that you have the most concern about and who you will need to continue to review and monitor over a period of time.
Let's go back to the incident in the emergency department. Normally, an incident like this would result in a risk man having been entered. It doesn't appear that that was the case. Can you talk about the processes that you would normally expect following a blood exposure in emergency department?
Well, it's fairly straightforward that where it does happen, they report it directly to the person in charge in the department itself. They themselves, or usually a nurse, will enter it onto risk man as an incident that's occurred, and then they will go through the processes of trying to look at whether they've been exposed to a virus or not. And that will usually mean testing the blood of the patient at the time. Again, you need to seek their permission to do that. And then you will need to test the surgeon again, a baseline test to see what the current status of immunity is. And then again, at regular intervals, up to a period of usually 3 months, to ensure that they haven't become positive over that period of time. And again, that's in alignment with what the policies would normally show. The other thing that is very important is providing some counselling and support, again, as a duty of care to your employees, and making sure and checking in with the surgeon, how they're travelling, how they're feeling, what they're doing. The question will come then, if they have, depending on what their blood test shows, if they have immunity, then obviously you're not going to prevent them from doing anything, and they continue on their normal work. If they don't have immunity and the patient was positive, then you might need to look at, do you again stop them from doing exposure-prone procedures because of the risk of them having been infected with hepatitis B. I think the important thing to remember is while we say that the vaccine gives you pretty good lifelong immunity, especially if you get another booster after about 3 to 5 years. There are studies that show that after 16 to 20 years, the immunity can start to wane. And there are studies that show that that's why we especially want in people who are doing exposure-prone procedures that they do check their immune status periodically to make sure that that is maintained.
Well, another element that comes into this whole investigation, because it looks like it was probably a workplace exposure, is work health and safety and occupational hazards and investigation of the organisation. Tell us about the role of work health and safety in an incident like this.
Well, obviously they'll be involved in this, and hopefully they'll be looking at risk man to see whether there's been other similar exposures in the past, to see how big a problem this is. They will need to obviously interview the individual in this particular circumstance to see what their normal behaviours are and whether this is the normal behaviours or a culture within the organisation itself. They would then assess what the ongoing risk might be to people working in those environments, and in that process they may then make certain recommendations about people working in those environments, whether they start to use face shields, whether they routinely use double gloves, whether they gown up in all situations. And again, they will often make recommendations which might be very hard to implement because staff won't want to adhere to it, and if that becomes a negative, then it will make it very hard for them to maintain that sort of stuff and sets up that sort of negative culture again. So it needs to be done in conjunction with the staff about what's practical and what's reasonable. So it's not a one-size-fits-all saying work health and safety will say this is what you all must now do under forever and a day. It's a matter of looking at what is realistic and what's practical, but certainly they should be involved to see whether they can see simple risks that can be mitigated and put in processes in place that can easily address some of these simple things going into the future.
So the surgeon's likely to seek compensation from the hospital. It was a hospital-associated exposure. They've suffered a material loss of income for an extended period. Would you support the doctor in their claim for compensation, even though it would likely increase your insurance premium?
As basically the person who is responsible for the actions of the employees within the organisation, whether they adhere to what they should have done or didn't do, they've been exposed in a setting which they had no control over, except possibly wearing a face shield and then reporting it from there, then I think you have to support this person, whether you're in a private hospital or a public hospital. I don't think that makes any difference whatsoever. The incident has occurred in the line of their employment. It's occurred within a setting that you have asked them to work within, and they've been obliged to work within that setting. And I think because of that, you have an obligation to ensure that you support them through this process, which means being compensated for the future loss of income, loss of reputation, loss of satisfaction through the work that they're doing. So I'm sure there'll be lots of stuff going through. Now, the workers' comp and the insurers' arms they'll look about what was the contribution from the surgeon from not taking adequate care and all the rest of it, but that's a separate issue. I think you as the employer should be supporting your worker in these settings at all times, one, so that you can ensure their well-being, but even more so their mental health can suffer through this if you don't give that right sort of support throughout the process.
The final one I wanted to quickly talk about was media. And there's incidents like this involving potentially a number of people, particularly if you've done a look back and started contacting past patients. Very high risk of media exposure. How do you manage that risk?
That's very simple and straightforward. Certainly in the setting here in New South Wales, it makes it very simple because it's handled by the ministry, because this goes through the Bloodborne Virus Advisory Panel and through the Chief Health Officer. They handle all that communication. It's done confidentially. It just says that there has been an exposure and that they are looking back for a period of time wherever the exposure may have occurred. And when I've seen them done here in New South Wales, they name the hospitals and they name the periods they're looking back over so that they can reassure people that if they haven't got your name, that we'll be chasing you up. And that, I won't say it's a regular thing, but it's done frequently enough that there's a good structure around that. And again, makes it very clear that this was no one's fault. It's just this is how we're trying to ensure that we can protect our community and that we can continue to enhance the reputation of the hospital, that we've got things in place and in train. So I actually think using the media is a very positive thing, not a negative thing, because it actually shows that you're acting responsibly and trying to assist people in the care as they go forward.
Thanks, Paul. A difficult scenario, not only for the surgeon whose life is likely to change, for the hospital and for patients. Any final thoughts on a scenario like this?
Look, it's probably not an uncommon scenario. Probably uncommon that they do become positive. You're more likely to see that with potentially other bloodborne viruses than maybe hepatitis B, because we know we've got that process of immunity. But it's a real dilemma. How do you put the public safety and the right of the healthcare worker to continue to practice without prejudice with this underlying illness is really quite difficult. Because you've got the three parties. You've got the consideration of the healthcare worker, who has a right to privacy and freedom of discrimination based on their status, and what this means to their future career and how they can contribute to the health system going forward, trying to look at how you can best place that person. You've got the right to the patient, who should have the right to informed choice and autonomy and protection from harm, and how you do that. And then the context of universal healthcare, where society is aiming to maintain an affordable and efficient healthcare system, you got to look at not putting too much burden incurred from permitting practice by an infected healthcare worker. So real dilemma, but one that does need to be handled very sensitively for the person involved, not just the patient, talking about here the surgeon themselves, and how we continue to monitor that into the future. But as a medical administrator, senior medical administrator, it's one that you must be prepared for, and you really have to think through how you best support that person going through this situation, while at the same time maintaining the respect for protection of the public and maintaining public health resources as well. But one that everyone needs to be prepared to face.
That was Dr. Paul Douglas, the Executive Director of Health Protection with the New South Wales Ministry of Health. And that brings us to the end of this episode of Safeguarding Healthcare. I'm Dr. David Rankin. Follow Safeguarding Healthcare free on Apple Podcasts, Google Podcasts, Spotify, or wherever you listen to podcasts. This podcast is produced by Sound Cartel for the Royal Australasian College of Medical Administrators.